Okay, good morning, everyone, and welcome again to our CME. It's the second Wednesday in July, and this will be our last CME before we take a break for the summer, and we will be back again in September. So it's 8 a.m., and we will get started. And this morning, we have joining us Dr. Christopher Newey, who is joining us from his post at the Cleveland Clinic. And so I will go ahead and introduce Dr. Newey, and thank you, Dr. Newey, for joining us today. And so I will introduce Dr. Newey before he gets started. So Dr. Chris Newey is a staff physician in the Neurologic Institute of the Cleveland Clinic, where he works in both the Neurological Critical Care Unit and the Epilepsy Consulting Team. He serves as the medical director of the multimodal monitoring program of the Cerebrovascular Center and as the medical director of the Neurosciences Intensive Care Unit at the Cleveland Clinic, Akron General. As part of the Epilepsy Consulting Team, he is responsible to the staff and on staff, the average of 55 EEGs daily. Dr. Newey is active in the Neurocritical Care Society and lectures at the NCS annual EEG workshop. So thank you for joining us this morning, Dr. Newey, and you can take it away with your topic.
Excellent. Thanks for the introduction, and definitely thanks for having me. I was hoping to be in person. I've never been to the Bahamas, but I'm sure it's almost as nice as Ohio, especially in the wintertime. So I'm going to minimize my screen here, my picture, so I can see my slides. Hopefully everybody can hear me. And again, thank you for having me. And today we're going to talk a little bit about status epilepticus. My talk is going to kind of walk through a little bit about where are we and how do we get here. And you'll understand a little bit more as we go here. And I have no disclosures. I saw this slide on Homer Simpson just recently, and I really thought it was fun. Just the different times if you watch Simpsons, he does this periodically in different episodes, and they took it all and made a seizure slide of it, and I thought it was pretty nice. So the outline today is I'm going to present a case. We're going to walk through the case. It's going to highlight a little bit of what we're going to talk about. Then we'll talk about the seizure definitions, identifying seizures, particularly with the EEG. That's kind of my specialty in the multimodal monitoring is what we do. And in multimodal monitoring is anything like neural exams, or you've got ICP monitoring, intracranial pressure, or pupil assessments. It can be anything you want. It's just taking a lot of different modalities and just monitoring a patient. I'm going to talk a little bit about management of seizures, and really that's going to be a brief slide. And we were just chatting before we started here. And initially I walked through the entire history of some of that, and it took my slide deck up to over 100. And I thought that was a little too much. So I condensed it down to one slide or maybe two slides. And then finally, we'll have a summary. So the big thing is you can see they're in yellow. And feel free if you have questions, just holler. I had to minimize my chat so I can see my slides. I'm on a laptop here. And I've got a virtual screen behind me. So we have a 69-year-old man admitted for status epilepticus, came to the Neuro ICU. He has a history of right MCA stroke back in 1990, so about 30 years ago. History of hypertension, migraines, recent UTI. He's fully independent at baseline despite his prior MCA stroke. He gets around quite well. History of only one seizure. Is not on any anti-seizure medicines. ASM is kind of the new abbreviation people are using. I'm still trying to get used to it. Instead of AEDs, we're using ASM. So you can see here on his MRI, I have circled here on the right side of the screen his flare imaging. You can see the image or the damage from his right MCA stroke there. He does have a little restricted diffusion down at the bottom left, but nothing really otherwise. But so nothing really acute on this MRI, but he was seizing. Why found him seizing in the shower? It's unclear how long he had been seizing. When the EMS arrived, they gave 6 milligrams of IM midazolam. It reportedly aborted the seizure, so he quit moving. He just quit. He just all of a sudden he no longer had that convulsive aspect. He was transferred to our ED. GCS3 on arrival, was intubated. Shortly thereafter, he had right arm, face, clonic activity, and was concerned for ongoing status, but that quickly aborted too with additional midazolam. I'm going to jump to this EEG here, and you can see here What I have circled in red, but just to orient you to the EMG, this is the double banana montage, kind of the classic way it's called, or the bipolar. Here where we work, we have the temporal chains on top, and then we have the parasagittal chains on the bottom here. So odd numbers are left, even numbers are right. So you have left temporal, right temporal, left parasagittal, right parasagittal down here at the bottom. So if orient that, so you can see here, this is the odd numbers, and you see this periodic discharge. So we call this lateralized periodic discharges, or periodic lateralized epileptic discharges, PLEDs, the old term. But you see it's on the left side, and his damage was on the right. So that was kind of interesting. But his right side was pretty flat, so he doesn't have a lot of neuronal firing on that side for the EEG to pick up, at least. Then you see here in the left parasagittal chain again, you can see this evolving rhythm, also that the lateralized periodic discharges disappeared, and you see this faster frequencies coming here. It gets more rhythmic as you go along here, more delta activity, which is slower, and it gets these 1 to 2 hertz waves, and it starts picking up again and starts picking up a little faster. Then it starts getting more rhythmic delta activity, more sawtooth looking. And finally, it kind of aborts here at the end. I always tell my residents and fellows, when the EEG starts looking like normal sinus rhythm, or becomes more normal, or like a heart, you think it's probably a seizure. The brain likes to be chaotic, like almost like a VFib. Just kind of give you a quick, my 2 cents overview. He was treated with a lot of medicines. He was treated with fosphenytoin low, the maintenance, levetiracetam low, the maintenance. He was still seizing. Over here, I took a screenshot of his the markings from the EEG, and all the red dots or red squares are just a seizure. But you can see it's all within just 1 hour. And so he was seizing quite a bit. And these were all without clinical signs. And this, with all this seizure activity, we just kept escalating, zonisamide, valproic acid, phenobarbital, finally ketamine, which stopped the seizures. So like I said, all these seizures were without clinical signs, which makes it challenging. So if you're not seeing convulsive seizures, then what do you do at that point? So that's kind of what we're going to talk about. It's what I always like to talk about. So the questions we want to learn a little bit today is, how should we monitor patients? Which and what dose of benzodiazepine should use, or anti-seizure medicine? And what is the first anti-seizure medicine after benzodiazepine should you use? So these are things that, whether or not you recognize it, but these are all questions that's happened in the last 20 years. And some of these are stuff that we've only recently started getting a little bit more information on. So just some quick background, and some of this background may be a little older, but it's still relevant. Status epilepticus is a frequent diagnosis in the emergency department and intensive care unit. As you all know, hopefully, that it's difficult to classify, it's difficult to recognize. It can be refractory to our standard anticonvulsants, such as our case presentation here, and maybe a source of morbidity and mortality. It's got an incidence of 150,000 cases of generalized convulsive per year. So these are the convulsive, the motor aspects. In the ICU, we see generalized seizures about 8%, electrographic seizures in another 10%. And we'll talk about this more in a little bit, but the number is a lot higher as we've actually started monitoring more. And hypothermia after cardiac arrest has seizure frequency about 20%. The definition of status has really been evolving over the last 20 to 50 years here. It really began in the 1960s to 70s, 80s here. We initially thought it was about 30 minutes, and a little around that time, because that's when they had animal models showing that there was some damage at the point. So about 30 minutes is when you start seeing the damage. However, in the 90s, we started like, well, you know, it's a long time to wait and watch someone actually convulse. So maybe we should break it down to like 20, 30 minutes. Finally, the late 90s is when we started getting a little bit more aggressive, and we started saying, well, how about 10 minutes? How about 2 to 5 minutes? So you can see this transition from it's more of a, well, you got some time, to more of it's an emergency, let's act now. And the reason being is that when we started monitoring more and more of these people, especially in the EMUs, PMUs, the epilepsy monitoring units, we started realizing that most seizures will stop within 2 minutes. So if you're already seizing past 2 minutes, you're outside you're out the standard deviations away from the median there. And that's important because it's hard to recognize seizures. We have these different ideas of what we may see with seizures, and what highlights our stomach to say, hey, this person could be seizing. It could be either prolonged postictal state, it could be acute onset of impaired consciousness, fluctuating mentation. It could be impaired mentation with myoclonus of the face or nystagmus eye moves. I highlight that one just because that seems to be a pretty good one to follow. Episodic blank staring, aphasia. Aphasia without acute structural lesions, another one. Just some kind of neurological change that really doesn't have a structural lesion. That's concerning. But you have all these different ideas what could prompt you to think, hey, this patient could be seizing. However, it's not always right. There's a study here from the Neuro ICU, a hospital, and 208 patients. And what they did was that they looked at patients from the ED with acute changes to neurological deficits, loss of consciousness or unclear motor phenomena, put them on EEG. What they found is that 13.9% were actually diagnosed with seizures in the ED were incorrect. 15.6% were admitted to the Neuro ICU, diagnosed with seizures that was missed in the ED. So in the ED is the emergency department. So that just automatically says, well, we're just, it's tough. And this is a third of our patients here that we're either misdiagnosing or underdiagnosing. So it is concerning. So we'll talk about later about some things that we can do to optimize that. Seizure-like movements are not always epileptic. And this is another Neuro ICU study, and another hospital. They looked at 52 video EEGs over 18 months. And they include studies for possible seizures due to motor phenomenon. People that just had some kind of twitching movement, et cetera, et cetera. And what they found is that those patients who had EEGs that people thought, hey, they could be seizing because they have a twitch in their face, twitch in their leg, arm, their movement. And what they found is that, 27% were actually seizures. So that's only about, a fourth? So 73% were actually not seizures. So again, it's hard to actually diagnose these patients by your clinical assessment. It's not to say that you shouldn't have a low suspicion and want to assess them, but it is challenging. This is a classic picture here, just showing what happens as patients seize. And really the big one is that the top part, that motor part, you have the generalized convulsions as time goes on the x-axis. You start going from generalized convulsions to myoclonus. Finally, you may get this electromechanical dissociation where you have EEG activity, but you're not moving with the firing. So, and as that time goes on, you see how it affects you systemically, affects your brain damage or brain metabolism, and eventually causes brain damage. And we'll kind of walk through a little bit of this. But the big thing is that as seizures go on, it becomes harder to treat, but you also get this electromechanical dissociation that just makes it more challenging to recognize clinically. So one of the questions people often ask, and this is kind of a busy slide, but does seizures or status epilepticus cause neuronal damage? And in the late 90s, early 2000s, there's look at maybe patients with ischemic strokes, intracerebral hemorrhages. And what they found is that people with seizures, particularly in ICHs, intracerebral hemorrhage, had worse NIH stroke scale, and they had increase in midline shift. Whether or not the damage from the brain, from the hemorrhage and the damage from that, or if it's the seizures causing, but they did seem there's something there, like there is a little, something that could be going on. What we do know is that seizures do cause increase in extracellular brain glutamate that leads to excitotoxicity. And as that excitotoxicity goes on, it can cause some neuronal damage. And the neuronal losses, particularly at the neocortex layers in hippocampus, thalamus, cerebellum, and amygdala. And if you look there at the top right, one thing that you can see in this image is a patient that presented to our hospital, and it was a young person. It was probably, I think, 18, 20 years old at this time. And first image at first MRI there, you see a very nice plump brain, but as the seizures were, he was in refractory status, and we certainly monitored him with EEGs as well as MRIs, and you see how just so much atrophy over time, despite all the aggressive treatment. Otherwise, I mean, it was just the seizures. I remember thinking he was in the hospital, but he was in refractory status. Other hospitals have noticed this as well and published their case patients. And I think it goes back to the, my internet is unstable. Hopefully you can hear me still. Highest in neuron-specific enolase is a marker of brain damage. And they started looking at this in the late 90s. And what they found is that this marker of neuronal damage, NSC, was highest in patients with non-convulsive status compared to other seizures. And it may be a little bit to do with just the brain damage from what causes non-convulsive status, or just the length of time that we have patients in non-convulsive status before we recognize it. But there is something there. And it's just something for us all to keep in mind, is that seizures is an emergency and we should act on it. And as we go through here a little bit in this paper here, on this graph, what you can see is that on the x-axis, that the maximum hourly seizure burden there, no seizures up to 20%, 20, 50%, 50% more. 20% would be about 12 minutes an hour. And you can see there, it seems about that 12-minute time is when you start having neurological decline in patients. So it's not to say that you should wait 12 minutes, but it goes to that very beginning definition of what seizures are. When we start with 30 minutes, 20 minutes, 10 minutes, 2 to 5 minutes, is that, well, if you start seeing some worse neurological decline around 10, 12 minutes, then, acting on it earlier is probably important. How long can we let people seize? There's another paper, it's a little older, but this is from the 1990s. You can see they're in hours. But on the x-axis, you have 10 hours, less than 10 hours, 10 to 20 hours, and more than 20 hours. And the bars, the white is the home, patients discharged home, patients who are disabled, patients who are deceased. What you see is that it does seem to have an increase in morbidity and mortality as patients seize. And this is just their total burden. This would be actually before continuous EEGs were really a thing. It's important to realize that I don't know like how your hospital does it, but there are a lot of hospitals are doing more continuous EEGs. Some hospitals do a routine EEG, which is about 20-minute EEG, and just do it frequently. But continuous EEG, where you just put it on and leave it, has only been around for just 15, 20 years as a thing, which is kind of fascinating. So we're learning so much about seizures in the last probably last decade. So that's why there's a constant change in definition, management, what to do. So it's an exciting time to be in it. So the mechanism of epileptogenesis in brain injury, as I mentioned earlier, it becomes more difficult to treat with the duration of the seizures. As it goes on, it just becomes more and more difficult to treat. Why do people seize? Our brains are always firing. It's always trying to seize. We have this intrinsic seizure threshold that our brain has, but it can be altered by brain injury. And so whether it's an intracerebral hemorrhage or ischemic stroke or traumatic brain injury or whatnot, but it does lead to us to be a little bit more susceptible to seizures. Doesn't mean that once a brain's injury, you're going to seize, but it just means that we are higher risk. And that's why most societies don't recommend seizure prophylaxis. They just recommend just monitor if you have a risk for seizures. But when you do start seizing, it becomes refractory, partly because the GABA receptors become internalized, and there's an increased number of AMPA and NMDA receptors. And you can see here in this cartoon, on the far left, you have a presynaptic neuron and postsynaptic neuron, and on the right, the same, but you have before status on the left and after status on the right. The little red dots are GABA, the little white dots are the glutamate. And you see the upside down triangles there being the GABA, and the upright triangles that are white are the glutamate. You see how the GABA, the upside down triangles start becoming internalized, and the normal, the upright triangles become increasing in number. And that just goes to show you why, let's say, some of your GABA drugs, such as your benzodiazepine, become a little less effective as seizures are ongoing, why it's really important to treat them early and pretty aggressive. So detecting seizures, we talked about, well, clinically it's a little challenging. So what do you do? Well, let's put the EEG on. Well, the EEG can be a little challenging too. So it's not as clear as we all would hope it'd be. And this is where a lot of the monitoring is becoming a little bit more and more important. It's an exciting time because we're just learning so much. This is a kind of an older image here, but it kind of shows a little bit of some different patterns that you may see on EEG. And what they call the top one, the discrete, where you see an abrupt start and abrupt end. The waxing and waning, you kind of see this increase in frequency, kind of decrement, increase again. So it kind of waxes and wanes there. And a lot of these patterns you may see more, let's say, in the cardiac arrest patient or the hypoxic ischemic encephalopathy patients. And the bottom one is that fixed frequency. It's maybe also known the invariant pattern, where it's just like 1 hertz. It's just one firing every second. And so all throughout our literature, it kind of has these described as different varieties of seizures without really having a definition of what a seizure would be on an EEG. And that's why it's really, the literature is is really evolving recently, just because I think we're becoming a little bit more standardized in how we're reporting these. So it's helping out with just our understanding. And so in the last probably 10 years or so, there's a group that met in Salzburg, Austria, and they kind of got together and said, hey, let's just start defining what we think a seizure should be on an EEG. And so what they said is that epileptic discharges, like a spike or a sharp wave, a discharge at 2.5 hertz or more, or an epileptic discharge that's less than 2.5 hertz, or some sort of rhythmic delta theta activity, which is about more than 0.5 hertz, and one of the following. So if you have the discharges, you must have one of the other things, such as EEG and clinical improvement after IV anti-seizure medicine, or subtle clinical ictal phenomenon during the EEG pattern, or a typical spatial temporal evolution. It's either that's where you have the incrementing onset, the evolution and pattern, or decrementing and termination, as we talked about in the previous slide. So they're trying to get a little bit more, a better idea, because if I'm going to go back here one slide, that bottom image is just 1 hertz. So it's less than 2.5 hertz, but there for a while, that was considered, some people were calling that seizures in literature. And you can see that. And so it kind of biased some of the literature early on, and really it's made it the last 10 years probably the more important with how we're understanding seizures. And this is just a nice little flow chart of how you should use what they're describing, such as epileptiform discharges at 2.5 hertz or less or more, and kind of walk your way through and just see, okay, do I think this is seizure, yes or no? And it seems to have a pretty good diagnostic accuracy and inter-rater agreement. So it seems something that's suitable for implementation in your clinical practice. So I'm not sure if y'all have seen this, but it does seem to have some valid and merit. And so that kind of leads to my interest. And my interest is that continuous EEG, and just putting the EEG on and just monitor the brain for an extended amount of time. One of my partners here at the Cleveland Clinic, he made the slide, and I give him credit for it, Dr. Hantis. And I find it very fascinating that a lot of times we'll have patients in the neuro ICU, they'll have the telemetry monitoring on, they'll have the heart rate, we'll look at their SpO2, we'll look at their temperature, as you can see there on bottom right, but they may not be on the EEG, but yet they're here for a ischemic stroke or a hemorrhagic stroke or a traumatic brain injury. We're monitoring the heart like none other, but we're kind of missing the brain, and really they're in ICU for the brain. So I look at the continuous EEG as a telemetry of the brain, and I understand resources. It's a resource limitation device. So, but I think with time, we're going to catch up. There's a lot of companies out there that's really improving the way we can monitor. And even when I looked at the PubMed, which is our database for articles, and even when you look at PubMed and look at the time of, let me move one of these things here, so I just cover my slide. As you look from time here on the x-axis from the 1950s to 2020, it kind of dips off there just because the 2022 is not over yet. But the interest in continuous EEG and articles being published has just drastically increased since 2000. So as I mentioned, up until 2000, continuous EEGs really just weren't talked about and wasn't really much of a thing. So our understanding is just really increased in the last probably 10 to 20 years here. And when we look at our own database here at the Cleveland Clinic, up until 2018, I have this slide, but the evolution of continuous EEG has really just continues to improve. And we have 11 years of continuous EEG monitoring here. And what I want to show you is that the orange line is our total number of patients monitored, as you see on the far right y-axis. But the bars are the number of seizures that we've been capturing each year from 2008 to 18. So as you can see that really as our number of monitoring increases, our seizure detections also increase. And really, we're just getting to a point of around 10 to, I would say about, I don't know, about 10% to 12% rate of finding seizures in patients we're monitoring. There at the beginning in 2008, it's like 50-50. We put the EEG on, we're about 50% chance of capturing one. And really what that was just telling us is that we were just under monitoring, and we were missing so many EEGs because our patient population hasn't changed. Our number of patients really hasn't changed, but our number of patients we've monitored has really changed. So, and really we've noticed that people with sepsis, they're high risk for seizures, and different brain injuries have different risk for seizures. And importantly, in that pie graph there, in 2013, what we just took a sample there of just our number of seizures. For example, most of the seizures we're finding are without clinical signs, 68%. So 32% were some kind of semiological findings, such as eye twitching or arm movement, leg movement, facial twitching, just something that had a semiology with it, but the majority of patients are still without clinical signs. So it goes to talk about, if you're not monitoring, you may not recognize it. And, it's the same thing. It's like, if you don't have people, say you don't have a cardiac monitor on or a telemetry monitor, you may miss the AFib. Some don't realize it. And so that's the same thing. Going again with seizure prophylaxis, I always talk about, well, we don't prophylax against AFib in just normal people. I don't see the reason prophylax with seizure meds in most people either. So, but that's something that's important, is that most of our seizures are without clinical signs. So unfortunately, given the resources, we cannot hook everyone up to EEG. And I understand that. I worked at a hospital before that we had 4 machines in the hospital. We had people on status a lot of times that we just weren't able to get hooked up to EEG in a timely fashion, just given our resources. So it is a resource intensive device. So a lot of the programs that we have, a lot of the data we're getting in the literature right now is probably from mostly just a couple of institutions, just because it is such a resource limitation. So there's something to keep in mind. So this kind of goes into my interest is, can we target who to monitor? And a couple of years ago, we looked at some of our data here. And what we found is that we looked at about 4 years worth of EEGs, about 1,200 patients, 1,1200 patients. We found that out of those patients, 19% had seizure on the EEG. Vast majority, 90% were non-convulsive. So even in our summary or our selection, we have some biases here where early on, most of our seizures were non-convulsive that we're finding. And as we're monitoring more and more, we're getting a little bit more semiologies. I think our cameras are just probably getting better too. We can see better. But and 21% died during hospitalizations. Those who did not have seizures were more likely to be discharged home. So there is something about morbidity and mortality there too. But again, the key here is just the frequency of seizures, and most of them being non-convulsive. So when we looked at etiology, and if based on different brain damages, and we've kind of broke it up here. We have our CNS infections, different hemorrhages, hypoxic ischemic injury, our metabolic sepsis patients, medical ICU patients, our ischemic strokes, tumors, traumatic brain injury, et cetera, et cetera. You can see over here in that grayish box, our odds ratio of finding different seizures in these patients. And you can see it's probably the highest in certain ones. And we were really surprised that with hemorrhage, it was not as high as we expected. And particularly the subarachnoid hemorrhage patient population, we just weren't seeing it like I think the literature had reported at that point, just because, I think it was selection biased and just the better understanding of patterns now. But it does seem like there is a stratification of patients based on their etiology. So we have something with etiology. So what about mental status? And we started looking at mental status as well, whether or not their patients awake, let's say lethargy, stupor, coma, based on the old classification here. As patients become more encephalopathic from awake to coma, their odds ratio for seizures actually increased. And you can see here on this slide is that the percent yield of seizures increased as mental status decreased. Again, awake, lethargy, stupor, coma on the x-axis, and you see the odds ratio increasing and the percent finding of it. So now you're looking at, okay, we have patients who have, let's say, a hemorrhage in the head who are comatose. You start getting this idea that they're at higher risk for seizure, or patients with a tumor, a meningioma, and they're stuporous, higher risk for seizures, versus that, let's say that subarachnoid hemorrhage patient is awake, lower risk. So we're starting to stratify our seizures based on etiology and mental status. So I think that's something to keep in mind. So getting a little bit away from just the clinical presentation, but also how's your exam in etiology? And now the question is going to be is, well, what about the patterns we're seeing on the EEG? And it seems that the patterns also can be telling. As you can see here, this is a classic picture that came out in the early 2000s, and it's called the ictal-interictal continuum. And so what they found is that, or they described in this cartoon, is that on the x-axis, the interictal to ictal part, but on the y-axis, potential for secondary neuronal injury being from low to high, the different patterns you may see from burst suppression, the SB, the triphasic waves, TW, and some of these older terminologies that they used, PLEDS proper, PLEDS plus, SERPIDs, and GPEDs, different patterns and what you may see on the EEG. PLEDs are periodic lateralized discharges, GPEDs to generalized periodic discharges. And you see there that even these different patterns seem to have some meaning on whether or not they have a seizure risk. So even in the early 2000s, we started realizing that there's some changes there and some things we should be mindful of. So that goes back to what we were doing here is that, well, when we looked at ours, going the PLEDs or the LPDS, lateralized periodic discharges, and the generalized periodic discharges, then I kind of broke it up to triphasic waves, only because what we found is that triphasic waves almost seem to have a protective effect from seizures, in the sense that if you see triphasic waves, they're more likely not to have seizures than just multiple, just different patterns. But highlighting there, the lateralized periodic discharges seem to have a higher odds ratio for seizures in our patient population. So again, you got mental status, you have etiology, now you got patterns on the EEG. It's kind of telling you a nice little story of seizure risk in these patients. And here we looked at our lateralized periodic discharges. Even them, those patterns can also have different meaning as well, whether or not it's more of a blunted delta, more discharge, getting a little sharper versus having some faster frequencies, a little beta activity on top of them. And finally, this rhythmicity where you have this periodic discharge that just all of a sudden just goes, becomes more organized there or chaotic. And so it kind of tells a story that, well, the odds ratio for those also increases too. So not only can we tell like the different patterns, but even within the patterns themselves seem to have meaning. So there's a lot to come over the next, I think, probably the next 10 years. I think we're gonna learn so much on EEGs and be a little bit better about our detection as well as what to do. And hopefully some detection softwares will improve as time goes on too. And that kind of goes into some of these other groups here. And what they've noticed too is that lateralized rhythmic delta activity and the lateralized periodic discharges also seem to have some seizure risk. And I like this cartoon here that they made, looking at the frequency on the x-axis and seizure risk being on the y-axis. And what they found is that lateralized periodic discharges, or lateralized periodic discharges with some of these plus features, some of that faster overriding fast activity we talked about, or PLEDS proper or PLEDS plus in the older literature, I mean, you see that it seems to have a seizure risk no matter what frequency. However, the delta activity, the generalized periodic discharges seem to have a seizure risk based on frequency. Then taking this a step further, and what they found is that around 2 hertz, it seems to be the change where you start seeing some of these periodic patterns causing neuronal or causing some seizure activity. And particularly when they did these studies, and they have like these different types of intracranial monitors. And in this case, you have the brain tissue oxygen monitor. You have a scalp EEG monitor, and they also have some depth electrodes as well. But in this case here, you got the brain tissue oxygenation here on the y-axis. You have the frequency of periodic discharge here on the x. And what they found is that the brain tissue oxygenation decreased with the faster frequencies. There is some the effects on the brain with the different discharge frequency. And interestingly, is when they started looking at the time to onset of these discharges to the brain tissue oxygenation again, they noticed that the onset of the brain tissue oxygenation started changing about 5 minutes or so before the brain tissue oxygenation changed. Or the frequency of discharges or the seizure occurred. So even early on, you're starting to see changes. Then finally, you see it on the electrodes and the discharges. So it just seems like around 2 hertz, there is a something there. So that's why we're getting back to that Salzburg criteria that they came up with, that 2.5 hertz seems to be pretty important. And so so much we're learning as time goes on is that we see these discharges on EEG, but some of them may not be felt, but then sometimes when they get the frequency changes, you start seeing a little bit more changes, and then you have to be more worrisome of seizure activity. So this goes to one of the other patterns that they recognize, and this is called SIRPIS, the stimulus-induced rhythmic periodic or ictal discharges. And in the early 2000s, they monitored some patients. They started noticing that when they come in, there's a stimulus, a patient that will have on the EEG this rhythmic pattern that starts evolving, has an abrupt start and stop, as you can see on the EEG, and I have highlighted here in the red box. This is a 61-year-old person with a right frontal GBM in this case example in the literature. Staff enters a room, slams the door, and you see this rhythmic discharge evolving here, and it has an abrupt start and stop. And so what they looked at, they found 33 patients to have these SIRPIDs. 24 of the patients had acute brain injury, and 17 and 33 actually had seizures. And so even still, I mean, there's like these different patterns that we're noticing that may be meaningful. Another one that's starting to get a little bit more press in the literature is the birds, the brief potentially ictal rhythmic discharges. This is another one which we kind of almost call rhythmicity in our example with the lateral periodic discharge that I showed you earlier. But this happens about 2% of ICU EEGs in this case, at this hospital. And there's a high prevalence of EEG seizures that it seems to occur before, and you may see these happening before the EEG seizure. I mean, the thing is, you start looking at these, and the thing about it is that, well, okay, seizures, they're starting to say if it's non-convulsive, you're seeing on EEG, it needs to be about 10 seconds. These are about 1 to 3 seconds, up to 9 seconds. So almost always like short seizures. So I think there's more to be said or more to be learned about birds. If you start to see them, the questions you need to ask yourself is it just a short seizure? Things that we just need to learn in literature. We're just not there yet. But now the question would be is, well, okay, so we have them on the EEG. We have a patient with a hemorrhage in their head. We're seeing these patterns on the EEG. They're comatose. They're high risk for seizures. How long should we monitor them on the EEG? And this is one of the things that we start looking at is, well, what if we just hook them up versus we have them on 24 hours, 40 hours, 72, 96 hours. And what we found is that we probably need to monitor longer than we think. We hook patients up and we monitor for 20 minutes. And these are patients who have percent seizures detected, x-axis, time of onset on the x-axis, and percent of seizures detected on the y-axis. What we found is that at 20 minutes, we're only detecting about 42% of people that we're going to seize, that actually we're going to seize. So, but as time went on, we've got about 24 or 40 hours, we were detecting about 92 to 97% of seizures in patients that we're truly going to seize. So these are just, we took patients that had seizures and we said, okay, at what point did they seize? At what point did we start detecting them? And so it really just highlighted that you're not going to, if you really think someone's going to seize or has a high risk for seizures, you probably should monitor for 24 to 48 hours. It's just, that's what we're noticing, and it just seems to be what other hospitals have noticed as well. So that kind of goes into the question is, well, can we stratify people? We've got a nice story here of different etiologies, the different mental status. What about what we see on EEG? A group here came with this scoring method called 2 helps 2B. It's a very nice risk stratification scoring tool that uses different findings, and they give you a score. As you see there in the findings, I'm not going to read that to you. But the thing about it is, again, it puts a lot of emphasis on that birds, and that's something that I think a lot of us are struggle with, because that, if you're what's the risk for seizure, and you're including something that could be a seizure, it may have biased it a little bit, and so that's something that we're all a little careful about using that. But I think it's a great step forward, and something that we can really take and hopefully learn from and develop further. Something that we started doing here is that we started looking at, can we make a machine learning algorithm, a model to predict seizures? And what we wanted to do is look at the dynamic and static information. And Dr. Amin here was a machine learning expert, and he really took this and helped out, because how I mark an EEG may be a little different than how you may mark the EEG or interpret it. And as you can see there, it's like really over the last 20 years, I mean, we're still evolving, and there's still a lot of subjectivity to EEG. And so, but if you're marking something lateralized periodic discharge or generalized periodic discharge or triphasic waves, if you're consistent within yourself and I'm consistent with myself, that should be meaningful. And that's what we were looking at, is like, can we make a meaningful model of marking the EEGs and taking what you mark, what I mark, and what my partners mark, and make an algorithm? What we found is that we can make a really nice model, static and dynamic, meaning a dynamic model is like an EEG changes with time. We look at an EEG first in the morning, look at it at night. There's a lot of things that happens to patients in ICU. They get more sedated. They may lose their blood pressure, may change. There's a lot of dynamic changes on the EEG. And so we found that dynamic EEG changes are more predictive compared to static EEG changes in predicting seizures versus, these static, like, okay, you have lateral periodic discharges in one file of 5 days of monitoring. Well, versus that lateral periodic discharge to burst suppression to rhythmic discharges to over 5 days. So there is a dynamic process that can occur. So I think there's something there, and hopefully with time, we'll actually have some algorithms and be able to really take this to the next level. And so more to be said about this. And like I said, it's an exciting time to be in the continuous EEG monitoring field. So for the last few minutes here, I'm going to give some time for some questions, but I do want to just talk a little bit about we talked about diagnosing seizures clinically. We talked about the challenges with seizures and the clinical diagnosis, and we talked about EEGs and whatnot. As our example in our patient, he was on the EEG, non-convulsive. We identified that he had all these patterns and got a lot of medicines to stop his seizures. And so that kind of leads to this, and this is a little cartoon I made probably about 10 years ago now. So there's some new medicine since then, and I'll have to update this in the near future. But what I wanted to just highlight really is just that you have a presynaptic neuron up here at the top, the yellow star, a postsynaptic neuron here at the bottom. You have your glia over here on the far right, and we say when your interneurons are GABAergic over here on the left side. And I just want to show that you have an action potential going down your presynaptic neuron. Let's say your seizures occurring. You have your sodium channels, you have GABA channels, you have calciums, you have all these different receptors. And our seizure medicines, and granted, they keep coming out with new ones, which is amazing, and it's just awesome. They all work on different receptors. So it's important to think about that, because if you have someone that's seizing and they're seizing quite a bit, you don't want to just keep adding a whole bunch of medicines that only focus on the sodium channel. Perhaps you want to start thinking like, okay, I want to look at the sodium channel. Have I not hit that one? Have I focused on the calcium channel? Have I focused on the SV2A receptor? Have I focused on the postsynaptic receptors and the AMPAs and NMDAs, GABAs? So there's a lot of different ways and tools that we have to really just attack these seizures and these ongoing, the status epilepticus with our medicines right now. Similarly, you wouldn't want to add, for someone that has AFib, you wouldn't just keep adding beta blocker after beta blocker after beta blocker after beta blocker without thinking about, let's say, your digoxin or amiodarone or your calcium channel blockers or other medicines. So you really want to just think about seizures almost in the same way. And so that's how we view it when we do our consulting on these really sick patients that are in status. But I'm not going to read all these seizure meds to you, but I just want to highlight that aspect, is that we have a lot of targets right now. And take all those different targets and really kind of titrate it to the patient with side effects and what would work from the best. And we have someone still seizing, ask, have I hit this target? Have I focused on this? Have I optimized this one? And if you Google or go to a search browser and just look, you'll probably find a lot of these different images out there. And so I think it's something that's really not. One of my last couple of slides here, I just want to really kind of walk through how did we get to where we are with seizure management, particularly with status management, from the late 90s to 2019. So really, if you've been practicing medicine for a while, you may realize that in the 90s, 80s, we really didn't have a pretty good algorithm for like how to manage status. And if you've been practicing like 2000s to early mid 2010 or so, you started like, okay, you got an algorithm, and that's what everybody's been doing. But really in the late 90s, where things started changing how we manage status and treat them. And this is a VA cooperative study in the top left there in the green. What it did was compare 4 different treatments for generalized convulsive status epilepticus in the VA system here. And the reason why they used VA is partly because it was about the only thing that had a nice EMR at the time, and so they could use it. But what they wanted to do is look at lorazepam versus phenobarbital, diazepam plus phenytoin versus phenytoin alone. And when they did the study, they have these doses here, and they found that lorazepam was more likely to stop seizures than phenytoin alone, significantly more likely. And when you have subtle status epilepticus, say pretty much that nystagmoid or twitching or the electromechanical dissociation there, nothing's really all that effective. But as a first line drug, what they found is at the time is that lorazepam was better than phenytoin in the study, and significantly better. So that kind of gave us a little bit of the algorithm that we started using in the early 2000s, that, okay, benzos should be given early. And then after benzos, we started saying, okay, well, how about phenytoin next? Even though phenytoin was the worst drug in that study. Then the question now became is, well, what if we started treating seizures before they got to the ED? Let's say we now have the ability to give medicines in the field. EMS can help out, they can do this. And also thing was, what about which seizure or which benzo would be better if we did do that? So they looked in this study here in 2001, the pre-hospital treatment of status epilepticus, looking at lorazepam versus diazepam. And I did put the doses on these slides here just to kind of highlight how the doses of these different medicines kind of evolved over time as well. But what they found in this study here in the top right, the blue box, is that in lorazepam versus diazepam, lorazepam was the better out of the benzos. So we're getting kind of a nice little story here, is that lorazepam should be your first drug. Out of your benzos, it was the better one. So now it leads to 2012. We're getting some new medicines here. You got IM midazolam available. And now you're asking yourself, well, I'm in the field. I want to treat these people early. I know that's better, but let's say generalized convulsions, they're acidotic, you're having a hard time getting IV. So what about using IM midazolam versus an IV lorazepam? As you can imagine, the time it takes to get the IV, to get the lorazepam in, may affect the ability to treat versus just giving IM midazolam. And what they found is indeed that it was the case, is that if you don't have an IV, IM midazolam was better. However, if you do have an IV, it seems like lorazepam was better in the time from active treatment to cessation of convulsion. So the time if you actively treat to stopping it, lorazepam was better. However, if you look at just from opening box to giving it, midazolam was better because of the time it took to give the IV and other stuff. So that kind of goes to what I told the residents and whatnot here, is that if you have an IV, most patients in a hospital do, use Ativan or lorazepam. So that's your drug. However, you're in the field, you don't have an IV, IM midazolam is a great option. So you get a really nice story here from 1998 to 2012. What should be your first drug? And that's your benzo. Which benzo? Lorazepam, if you have an IV. So now you're asking yourself, what if they're still seizing after you give your benzo? And this is where it's really been kind of muddy and has up until this time, but we really, every time you have a new seizure med come out, we were trying it, a new IV seizure med came out, we were using it, but they started asking themselves, well, after you give your benzo and they're still seizing, what about your second line drug? Which one's better? And this is the ESETT trial, ESETT. And it was published just recently in 2019. And they looked at IV levetiracetam to IV fosphenytoin to IV valproate acid. And you have the doses there, and they did have maxes on these, but I do highly recommend you looking at this study because it's an important study for what we do. And so what they found is that really there was no difference between the 3 medicines as a second line drug. So if you have benzo, you give levetiracetam. There's really no difference between the 3 drugs. I have my opinions on these, but overall that's what it showed. So really, after your IV benzo, your next drug could be either levetiracetam or phosphatidone or valproic acid. If you're still seizing after that, we really don't have a lot of guidance on what to do still. But with time goes on, we'll keep improving our meds. We'll keep improving how we manage patients with our diagnoses and our ability to act on patients earlier. Because in the end, it may just be we need to give benzos earlier, recognize it earlier, and give the benzo earlier to stop the seizures versus waiting for a seizure to happen. You give your benzo, they're still seizing, then you give your second drug. Because if you look at that top left, that green slide I have circled there, the phenytoin alone as a first-line drug stopped overt status in 43.6% of the time. If you look in the bottom right, that yellow, and you see the phosphatidone there, and again, it's a 45% of patients have stopped their seizures as a second-line drug. So still, I mean, it's like, I'm not sure if we have the right meds or if we're still there, but it seems like your benzos are a really good drug if you can get them earlier. And I think that's the key. So this is just in summary, the continuous EEG is the telemetry of the brain. If the seizure, benzos, just remember, you got to give your benzos early. Lorazepam is your best. And then after that, it could be levetiracetam, valproic acid, or phenytoin. So I just wanted to kind of highlight here on the right side of the screen, just the algorithm that based on the data that we have available, what we use at our institution for how we manage seizures, particularly status epilepticus. And we broke it up into tiers, and we have some definitions there, but really tier 1 is lorazepam 4 milligrams IV, repeat it once. That kind of is consistent with the Rampart study that was done in 2012. Tier 2, you select one of these medicines, such as from the ESET trial. And again, I have there just the doses and some of the maxes that were recommended. And so you can see after that, what we do after tier 2 is, well, if they're still seizing after your benzo, after your phosphatidone, for example, maybe it's time to consider intubating and put them on a midazolam infusion. Then if they're still seizing after that, you got phenobarb, ketamine. Then tier 6, we just added a couple medicines here just to kind of give our ideas like, well, these are not status meds, but these are meds you can keep adding because eventually you want to get them off the midazolam, off the ketamine, and probably off the phenobarbital too. So I just want to just say thank you for having me. This has been awesome. It's always fun to talk about one of your passions, and this is one of my passions. I appreciate your time and inviting me. And if you have any questions, I'd be happy to entertain them.
Thank you very much, Dr. Newey, for joining us today. It was a pleasure to have you. And your passion shows. And thank you for that excellent presentation and overview on status and EEGs and continuous EEG monitoring. While we wait to see if there are any questions that may pop up in the chat, I have a question I want to ask. You alluded to the fact that sometimes a patient might present with aphasia without any acute structural lesion on CT scanning. And this is quite a common presentation for us. Or a patient is admitted for a TIA and they suddenly, what is, a diagnosis of a TIA, and they suddenly start deteriorating. We repeat the scan of the brain and it doesn't show anything. Deteriorating meaning mental deterioration. Are these patients you think that we should be treating for status?
I mean, honestly, I would put them on a continuous EEG and capture it if you have that ability. I always look at it like, okay, if you put someone on medicine, a lot of times when you put someone on seizure medicine, it's really hard to get them off. And you may have them on it and there's side effects of all these medicines. And so if you have the ability to diagnose it, I think it's great. In your case example there, I would put them on for 24, 40 hours and if there's no seizures, you can, okay, this is not a seizure, it's probably something else.
Yeah, we don't actually have access to continuous EEG monitoring, for our ward patients.
Yeah.
And for that matter, not for our ICU patients, to my knowledge. And there was another comment that you made. You said about 15% of people who were admitted for other things were actually diagnosed with status epilepticus. I'm not sure if I got that correct. Were those ICU admissions?
No, that was just an old paper from like early 90s. So there's kind of more of a convulsive. So no, you know, as we're monitoring more and more, we're starting to realize the incidence is probably higher than what we realize. And that's kind of going what I was trying to highlight earlier. It's just we're getting to a point where some of these institutions, you know, like the clinic, we have 40 continuous EEG machines, or roughly around there. So we can, if you sneeze, you can put on the EEG. I mean, we have that ability, which is a luxury we have. And some other ones like Yale and Mass General and Columbia can do some of these. So you do have a little bias sampling there, but I think as we monitor more and more people, we're realizing it's higher incidence than we realized. So I don't know if we really understand the incidence.
Okay, and to follow on from that question then, in your experience, what is the most missed presentation of status epilepticus?
Probably that patient's just laying there not moving, the comatose patient, or that patient's like in the medical ICU that's septic and a little bit of liver failure or something that's just not waking up. I think that's kind of the one that I'm always thinking of, because usually you have a hemorrhage or a tumor or something, you're like, yeah, okay, of course they're probably seizing. But I think the ones that are like, going to your point, is there's no structural lesion and they're just altered, something's wrong. I think that's where a lot of our focus that we at the clinic we've actually been doing is educating the medical ICU that sepsis is a higher risk, just inflammatory cascade can cause seizures and whatnot. But that's the patient I think's missed the most.
Okay, well, thank you very much. We are just on the 9 o'clock hour. And so before we close, do you have any final comments?
No, I really great. Again, thank you for having me. This has been great. Maybe next time you can have me in person, and in the wintertime, I'd really appreciate that. But
and so that's what I was going to say. Yes, we would be very happy to have you in person present when we're back to in person, and we could make sure it happens in the wintertime.
I appreciate it.
So thank you very much for joining us, and you have a great day.
Yeah, you too. Thank you so much.
Okay. And thank you to you, our audience, for joining us. And thank you to Dr. Halliday for our excellent IT services over the past couple months. And as we've said before, this is our last presentation until September. So we will break for the summer, and in September, look out for the notices. But our schedule is fixed, as you know, the second Wednesday and the last Friday of the month. And our Zoom link doesn't change. It's the same link for every CME meeting that we have. So you can hold on to it. Thank you very much, everyone, and have a wonderful day.